Dr. Aamir Ehsan, Vice President of HOPPE. He will be talking about demystifying NGS, ctDNA, and MRD testing in everyday oncology.
So cancer patient, as we know, every patient needs a second opinion, and patients deserve the best treatment and access to clinical trial. Opening clinical reality for this whole topic is we know that molecular testing is standard, and interpretation drives the outcome. From the pathologist's point of view, the interpretation is really the key. It's not the positive and negative result that you get from the machine. It's really the intensity of the intellect going on behind interpreting these results. And failure to act is a clinical error that we know. Goal of NGS testing is applicable to both hematologic and solid tumor malignancy, and that spectrum is pretty broad, as we know. The key thing is when it comes to the pre-authorization and reimbursement and all those kind of things, is we need to make sure what we are doing is making sense from the diagnosis point of view. It's going to impact the treatment outcome. The prognosis is going to be affected based on the test that we perform. And the clinical relevance is what kind of tissue we have. Sometimes we have just FNA from the breast biopsy or from lung biopsy. It's a very limited tissue. We know that the gold standard is always the morphology. Never do the molecular only without morphology, right? Now, another common question get asked is what's the difference between I would like to test few genes versus the whole exome sequence. The answer is, from the pathology point of view, it does not matter to us. If we need a small sample, we would rather do the whole testing rather than wasting that sample on limited genes, as we know that every week new mutation drivers are popping up, and we do have a technology that can do the whole exome sequencing. So I would prefer more is better. Patient deserve the best treatment and access to the clinical trial. But for the sake of comparison, I put together different key differences, specific genes versus broad-based, known genes versus coding, first tier, second tier. I don't want to go into the detail, but what I can say is the technology is available, and we can sequence enough data to give a meaningful result. Even if the data is not relevant today, it may be relevant the next month or the next year, as we know. Molecular terms, sometimes it's also confusing to some folks, are germline versus somatic or acquired mutation. There are certain cancers where the mutation is germline, even in cancer, especially when you have more than one cancer. And then, the application of in hematologic malignancy, we have seen quite a few cases missed based on just doing JAK and CALR and MIPL and other mutation of JAK. So if we are suspecting myeloid malignancy, definitely do a good number of genes to detect those few percentage of cases. And the list goes on, so on and so forth. I'll be talking about liquid biopsy, which is different terms use, ctDNA, circulating tumor cells. We know that sometimes these circulating tumor cells, as circulating cells are not there, that used to be detected by flow cytometry back then. Actually, these are DNA and RNA particles that are coming in the blood, and that we call liquid biopsy, right? We can do that both DNA as well as RNA expression profile in the blood. So where each tool fits in the clinical landscape, NGS is, of course, the baseline molecular profile. It defines the tumor identity at the diagnosis. Ideally, if I would like to have everybody's permission to do whatever testing I would like to do, that anytime patient is diagnosed on the morphology, solid tumor, it's better to have the liquid biopsy done at the treatment naive stage as well. So you know what's going on in the main parent tumor as well as some signature present in the blood, and then hopefully you can follow that as well. Because it's important to have the data up front. It's not approved to do that way based on the reimbursement and pre-authorization, but I think that's the right science to do. And then you can follow based on the MRD criteria. The ctDNA I just talked about, and MRD also predicting. We have seen cases, especially lung cancer, breast cancer, colon, where radiological changes are going to be happening like 6 months later, right? And liquid biopsy can detect these mutations. Speaker before me talked about positive and negative, which is important. A negative does not really help, a positive definitely, because these positive make sure that whoever is calling positive is a pathogenic mutation. It's not like of unknown variants or polymorphism and things like that. So we need to be carefully looking at the pathology report before we take the positive as a face value. So what actually matters clinically? Of course, the driver versus passenger mutations, the VAF versus tumor purity, the co-mutation biology, and certain mutations that are linked directly to therapy. Just for the sake of time, I'm not reading the whole slide. I'm just hitting the key points that are going to be the take-home message here. So what is the clinical thinking framework of NGS? Of course, the first question is this actionable? Whatever we are seeing is making sense. Does this change your therapy? I have seen some report like CSF3R mutation detected, which is seen in acute neutrophilic leukemia. But looking deep into that report, it was a polymorphism that was reported. It was not a pathogenic mutation. So that's why keep reminding that what we are saying is making sense. So does this change therapy? Is this resistance biology, whatever you see, anything down the road or even at the initial diagnosis? And the new entities, not a new entity, but relatively new, is CHIP and CCUS kind of cases that we are some cytopenias and we are seeing mutations which could have been missed on regular 4 or 5 hotspot that most people test, right? So the more testing that we do, it's better to have the data and then correlate with the clinical information. So ctDNA or liquid biopsy or a combination of both DNA and RNA expression profile in the clinical utility. Of course, monitor treatment response, early resistant detection, and surrogate when tissue is not available, and that need to be carefully looked at. So if you have a small core biopsy of the lung or the small biopsy of the breast, if it's non-diagnostic, you just cannot rely on the molecular and start chemotherapy. You have to have some evidence based on the morphology to start giving chemotherapy after the NGS is also back. So when we look at the lung tissue, we can see, okay, this is the small area where the tumor is, and we can micro dissect and then take that sample for NGS rather than doing, a bunch of other immunostain. Because RNA expression is what? RNA expression is a protein. And when we do all these immunostains, that's also protein. So that's another way of looking at mRNA. So we can save tissue by switching to RNA expression profile and make the diagnosis rather than asking more tissue after that. So this is a curve showing the falling VAF when therapy is active. And then there is a nadir here, and then the molecular progression initiate resistant testing before the next imaging cycle. So you can see the nice curve there. Practice changing prognostic tool. Of course, it detects microscopic disease, strong prognostic biomarker that we talked about, and it guides adjunct decision making. MRD survival curve versus positive and negative, and you can see the blue line is rapid DFS decline versus the orange line, which is the sustained disease-free survival. Molecular testing and therapeutic algorithm. This is how we practice most of the time, that comprehensive NGS panel is done. Back then, like few years ago, we used to do one gene and the next gene and then reflex and this and that. We know the timing is very important. By the time patient is being seen by the oncologist with tumor board, it's already 2-3 months late for the diagnosis, right? So it's better to do, whenever you have the sample, to do a comprehensive NGS panel to get the maximum data out, identify the driver mutation, and of course start the target treatment, and then follow up later on with progression, looking at the liquid biopsy. This is just an example. I don't want to go to the detail, but how the diagnosis is made and the first line treatment started, and then the molecular progression, and then another mutation detected in that therapy switch. And this happened, pretty frequently as the biology of the tumor changes. Breast cancer framework, I kind of highlighting breast, colon, and other tumor here. So breast cancer molecular framework of metastatic disease, you are familiar with hormone receptor, HER2 negative, the PIK3, ESR, and the role of ctDNA as well. Now, there is a discussion recently about ultra low HER2 neu. Now, ultra low is very difficult to pick up by morphology under the microscope. Most of the time, it's kind of negative. So that's a discussion that we can have later on. So I'm just going to switch for the sake of time and hit the key. It's definitely indicated in colorectal cancer. It's a few diagnostic pitfall when there is low tumor shedding, false negative, false positive we talked about, over-interpretation. The clinical decision rule, actionable mutation again, resistance mutation, MRD positive post-treatment, MRD negative post-treatment. This is my last slide and takeaway. What to treat is, of course, based on the NGS. What's happening when you start treating the patient and carefully monitoring it, and what happened next is the MRD. So the bottom line is, if I would like to convey my message to you as a hematopathologist or molecular geneticist, carefully look at the NGS report. Pathogenic mutations are there or not. Look at the allele frequency. Look at the original tumor mutation compared to the liquid biopsy, and make sure there are no germline variant that were called as pathogenic. So those are, and pick up the phone and call when things don't make sense, because you're making a big decision of giving chemotherapy based on these liquid biopsy results. Thank you.